Good morning, everyone. It is just now hitting 11, so we are going to get started. Thank you all for joining Health for a Change, Breaking Down Language Barriers to Accessing Quality Care. My name is Allie Wells. I am the Communications Director at the Foundation for a Healthy Kentucky. This webinar is approved for continuing medical education credit. As you can see on this list, all the planners and speakers have disclosed that they have no relevant relationships with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients. This activity has been planned and implemented in accordance with the accreditation requirements and policies of the Accreditation Council for Continuing Medical Education through joint providership of the Kentucky Medical Association and the Foundation for a Healthy Kentucky. The Kentucky Medical Association is accredited by the ACCME to provide continuing medical education for physicians. The Kentucky Medical Association designates this live activity for 1 AMA PRA Category 1 credit. Physicians should only claim credit commensurate with the extent of their participation in the activity. For those of you on this webinar today who want to receive this credit, there is a short post-event survey that you will have to fill out. There will be a QR code you can scan at the end, and once we get going, I will also put a link in the chat. Joining us today, we have Lynn Fors, Executive Director of Access Language Solutions, Isabel Taylor, Multi-Affairs and Title VI Coordinator at Global Lex, and Sarah Hessler, Language Services Director at University of Kentucky Healthcare. I am very, very grateful for all the hard work they have put into their presentations for today. They're all very passionate about this important topic. Language barriers and cultural differences in healthcare can lead to mistrust between patients and physicians, delayed or missed care, and in some cases, misdiagnoses. But there are ways to mitigate these challenges. Up on your screen now is some of what we will be covering in today's webinar. For those of you who are physicians, nurses, or anyone else with direct patient care, our goal for this webinar is to provide you with a better understanding of how to handle those language and cultural differences with your patients. And for those of you joining us today who are advocates or work in other ways in the health industry, our goal is to give you some insights into best practices that we can shape policies and programs around. So with that, I am now going to hand things over to Isabel. Isabel, you are muted.
Okay, sorry.
Hear you now.
Good morning, everyone, and thank you, Allie. We're going to start with examining how culture, our own culture, plays a role in communication with people from diverse parts of the world. We think of language as being our biggest barrier to effective communication, but there is an important and essential connection between our culture and communication. Wade Davis, anthropologist Wade Davis, says that we cannot help but communicate by behavior conditioned by our surroundings from birth, behavior so ingrained that it becomes subconscious. It would take much longer to go through every aspect of the links between communication and culture, but a professor like Angie Wilson would talk about how culture is like an iceberg, with the vast majority of the iceberg not visible. It's below the surface. And so it's been said that 9/10 of culture is hidden from view, our deep culture. Because our deep culture is so linked to how we understand our world, it also creates automatic expectations of what we see, what we hear, so that we and our clients sometimes make errors in very natural assumptions, assuming that others have our same understanding. Even though we know we are communicating across languages, we are also communicating across cultures. We'll examine briefly how language is only a part of professional communication skills and put this all in the context of language and cultural norms that may be present in our own areas, and provide recommendations as to how you can assess these diverse languages and cultural groups in yours. Go to slide 7, please. So with a difference in cultures, While a difference in cultures impacts both our own and our clients' ability to understand one another, it becomes really important to try to understand and be aware of belief systems of cultural groups in order to spot blocks to communication. And a caveat here, I'm generalizing to bring an awareness of possible differences, but remember how we describe a group of people doesn't mean that every family or member of that cultural group will have those characteristics. However, even exceptions will understand their own society's norms and expectations. So there are important differences in concepts of time, of space, of hierarchy, respect, gender roles. There are high and low context societies, and I'll briefly talk about our individual identity versus a collective one. In a lot of the US, we have a culture of individualism, the I identity, which briefly means to certain degrees, parents strive to teach their children to be self-sufficient, independent, and able to be responsible for themselves. Competition is rewarded. On the other hand, the collective or group identity, children are taught that they are part of a whole. Humility and modesty are ingrained, competition not so much. Obligations and dependence on the family, extended family, the clan, the tribal or cultural group is the base for this identity. One way this may impact communication and ultimately healthcare is that this collective reality may lead to a person's concerns with interpreters from the same community, where everyone feels they should know their group member's business and even be a part of that solution. It can be a barrier to disclosing intimate or important confidential information to you, the care provider. So there's important differences in concepts of time and space, hierarchy, respect, gender roles, high and low context in individual and collective societies. We know cultural concepts of time can be a problem, can be a challenge. Tracy Novinger described the US in her book, a comparative study of cultures, that if there were logos for the US, the clock would be the logo. Because for the most part, we plan and expect to schedule our lives, our work, and our social gatherings. We factor in things like how much time is it going to take to get from A to Z. But whereas other cultures, the present is more important than time. And time stretches depending on the circumstances. This is a natural response that comes from people from all over the world. People laugh when I ask friends from Latin America or Africa or the Middle East, are you talking about American time or other time, right? So it takes people from abroad a little while to understand the local importance of time, that time is money, by explaining that our concept of time is not only a practical commodity, but it's directly linked to manners and respect for the other person's time or other people. And they seem to understand it better when it becomes a matter of respect. We're said to belong to a low context society here. Time is of the essence, where speech is very direct. Social boundaries are more flexible and subtleties may go unnoticed. We have a low power distance, which means that the boss may be called by their first name. Parents treat children as equals, and teachers ask parents and students for input and participation, where medical care providers often expect the same. In other parts of the world, in high context societies, speech is not direct. And direct speech can be like a bucket of water. And one expects to talk around the point, giving extraneous, what to us is extraneous explanations, but deemed necessary to understanding the whole situation. They will describe A to Z. I will describe A to Z in that environment when you might only be interested in Z. Subtleties and manners are very important. There are class distinctions and hierarchies, or what's called high power distance, where professionals, teachers, for instance, are the boss. Parents are not involved. Titles are often used with most professions. People in these cultures may not be comfortable or indeed know how to ask or to provide you with information that you may deem critical for their care, particularly if they might be from a rural area. So cultural differences or expectations, how we understand our circumstances, even the words we use across languages, similar sounding words may have different cultural connotations. And I'll give you an example of the word intoxication. In the US, if you say that someone is intoxicated, you might mean that they are drunk. Well, in other parts of the world, that word sounds identical in French or close to Spanish, Slovak, Latvian, Portuguese, or Italians, but to those cultures, the word for intoxication means poison, and the words for drunkenness is ebrio, ebreza, ebrez. So we may think of language as our primary means of communication, but language is only part of our professional communication skills. An awareness of verbal and nonverbal nuances of body cues is highly recommended. To navigate that international milieu that we're in now, Kentucky has a very international population today. So communication is made up of so much more than words. Nonverbal cues such as tone of voice, gestures, and posture all may play a part. And just as with culturally different meaning to words, our body language can present different cultural understandings or misunderstandings. In the US, for example, I'll give you a few negative body language examples, a couple of them. Crossing your arms. In the US, it's defensive. You might be unhappy or angry, or you might be a dissatisfied patient. But for others in perhaps a higher context society or hierarchy society, the Bhutanese or the Nepali, it can be a concept of respect. Crossing your arms may mean, I mean you no harm. It may mean, I'm listening. Having your eyes downcast. They won't look you in the eye. Police officer might think they're hiding something. This is shifty. They're not looking me in the eye. But for some societies with structural hierarchy, this may be a form to avoid challenging your authority. It's respectful. So again, talking about other facial expressions, for instance. Mayan culture, Dr. Barrett explains, they have an aversion to showing a lot of expression, as do the Asians. They're more reserved. So the Mayan culture frowns on excessive displays of emotions. They may turn their body away from you, from an angry or highly emotional person, and it's to give them well-mannered space to not embarrass themselves. It's very different from our Western European cultures that the Hispanic community is from, which expects much more expressive hand and facial movements. Mayan children, unfortunately, are often misidentified as Hispanic, and this creates a huge barrier for them and their caregivers. They're not Hispanic in culture or in language. So let's go to the relevant context. Where do people come from? What languages and cultural norms or history of trauma are present in your area? That information is at your fingertips in a search engine such as Google or others. Let's go ahead and go to the other slides. We are going to be looking at the Lexington diversity, language diversity, and our top 9 languages are already in the 1,000 people area. So that means for Title VI purposes that Spanish, Swahili, Arabic, Nepali, French, Japanese, Kinyarwanda, Mandarin, and Korean need to have us us have those critical documents translated. So in May of 23, the public schools let me know that there were 103 languages, but Sarah and Lynn and others and I have tracked over time, over a long time. We've tracked over 210 languages. I've lost track of how many, but the active ones it's hard to say, but they are definitely over 100. Could I have the next slide, please? So how do I get my data, and how can you get your language information? The census calls, this could be called the English learner data or the limited English proficient data. The census calls it home languages other than English. So any of those terms, I use children learning English in the public schools because there is no main repository where people go and identify themselves as foreign language speakers. There is no place that I can just go to and say, oh, this is correct. So our local information is very important. At one point in about 2006, I saw that the Pew Center was using a chart where they said that school-age children, ages 5 to 17, are 10% of the total English learner population. I want to repeat that because that's important. School-age children are 10%. The children learning English are 10% of the limited English-speaking population. So that's a great number to work with, 10%. I do want to say that I ask every year, I ask the public schools for their number of children that are learning English and the languages that they are learning. And they explain, and I want to underscore that this is only a picture in time. This is only a brief moment in time where we see what the numbers and figures are, because children walk in and out of classes all the time. They learn English, they move on, or their families move away. So keeping that in mind, that the numbers change, but they are nevertheless really good estimates, I believe. And I'll tell you why. In 2010, we were estimating out of 3,200 school children that were learning English, we estimated that there were 32,000 total population of foreign language speakers. That meant 11.1% of Fayette County's population was foreign language speakers. That year in 2010, the census gave us slightly higher, 11.3% in the house-to-house count. And I was delighted with this because it was so statistically close, and it was even conservative. We were only 0.2% under our estimate was 0.2% under the census. In 2023, let's fast forward to 2023. We currently have about 10,678 English language learner students who speak over 110 languages. Why do I say that? And remember that numbers vary from day to day, month to month. But we got this number of students and this number of languages directly from the public schools because we had a mapping project which would show our council members and our first responders what languages were in what part of Lexington. So the local number of students gives us 106,780 limited English speakers in Lexington. That is a 233.7, almost 234% growth just from 2010. Next slide, please. So a major concern here is that the 2020 census in March of 2022 acknowledged undercounting minorities and kids, but neglected to mention severely undercounting foreign language speakers. And currently the census shows only a 2% growth from 2010. And we see that our local numbers show 234% growth. So it's grossly off, and that is impacting us for the next decade in terms of federal funding, in terms of school funding, in terms of even medical funding that we might get from grants. We did do language maps here in Lexington. This was for first responders, for our council members, and for our administration. And using those 10,678 public school children, we created the following maps. Can you give us the next slide, please? Thank you. This is just to show you what Lexington looks like, the first one. Can we go back? It just shows you 12 different districts. Forward, we can go. And I'm just going to show you a couple or 2 or 3 of these. We see school district 7, council district 7, sorry. We see 54 languages here. And one of the things that I want to point out is that in the public schools, Spanish, Swahili, Arabic, and so forth were the top languages. But in this particular district, we see that Nepali Japanese are ahead. And so if you have an agency that is only dealing or serving a specific area, you might want to narrow down your details and information that you give your first responders or your staff, so that they know what the top 10 languages, the top 5 languages are. We see also here that a lot of these languages, we see Polish, Italian, Bengali, a lot of these are just single family. The indication is 10 people with our 10% estimates. There might be 20 Swedish speaking people. For the most part, these people, I worry, are going to be in information isolation because they don't have the deeper groups, language groups like the Arabic speaking community or the Spanish speaking community that already have deep roots in these areas. Next slide, please. So District 9 has, again, different percentages and numbers of languages. Japanese here is the second highest, and then Chinese. So there's 47 languages there. Next slide, please. One of the things that surprised me was that District 12 shows 30 languages. District 12 is our rural area. These are farms. These are whether it's equine farms or cattle spreads or food growing areas. They have 30 different languages. I totally expected to see, and we do have predominantly Spanish, but we have 30 different languages, everything from Finnish to Chinese to Wolof. So you do need to worry as a first responder about the languages of lesser diffusion, or the languages where we have very small family groups. How do we reach them? Okay, next slide, please. So where do our international residents come from? Why here? Why do they come? I get this question all the time, so I went ahead and put it in here. Kentucky Refugee Ministries in Lexington resettles refugees, humanitarian parolees. The refugees might be Cuban, might be DRC Congo, they might be Guatemalan. The humanitarian parolees are mostly Ukrainian, Afghans, TPS, temporary protected status, or asylum seekers. The universities also are a source. They tenaciously recruit international postgraduate and doctoral students and professors for their highly advanced research. the patents they create, the inventions and innovations they generate, and the entrepreneurial and direct economic contributions. In 2017, that was the last year that I had information on their direct economic contribution. For just Fayette County, they brought in $65 million. 58% of that went to the university itself, and the rest of it was to the local retailers. Foreign-owned businesses, large and small, bring executives and key staff from all over the world. An example is Toyota and the 600 or more companies that supply them. Lexmark, A&W Root Beer, they're a Singapore company, but they have their headquarters here in Lexington. There's hundreds of smaller businesses owned by immigrants, like restaurants, gas stations, retail stores, construction companies, equine services, and more. Professional recruits. What do I mean by that? I mean that ballet dancers in the arts, in the sports area, in the other industries, baseball players, musicians, conductors, doctors, nurses, medical technicians, other high tech, especially in the aerospace industry. We have more aerospace engineers than other states. Lawyers, accountants, care workers, artists, chefs, many others. They're from around the world. Equine and other farm owners, as you saw from Rural District 12, they have professional trainers, riders, vets, handlers, agricultural workers from all parts of the world, and of course, owners from all parts of the world. I think that's it for me.
Thank you, Isabel. I interviewed a couple that I've known for over 20 years, and they've been in the United States on and off for 25 years. They're considered limited English proficient, and I asked them about their experience of the medical system as people who generally need interpreters. So that's what you're going to hear here.
Es más diferente de nuestro país, pero
It's different than in our country, but we are satisfied with the attention they have given us.
A mi hija o a mi hijo y por llamada, videollamada,
Sometimes I need to talk to my daughter or my son by phone or video call, and they help us with the doctor.
Lo que pasa que yo como entiendo un poco
What
más
happens is that I
inglés,
understand a little more English and I speak a little more English.
a veces trato de hacer una cita y si no me entienden,
So sometimes I'll try to make an appointment and they don't understand me. They'll tell me, wait, I'm going to look for an interpreter.
No lo encuentran.
But sometimes they don't find one.
Y no, o sea, no se puede hacer nada.
And so we can't do anything, and they tell me that they will call me another day.
Y le hablan otro día.
And they call you another day? No, not anymore. I have to find another way to make the appointment.
Oh, okay. Y esta puede tardar.
Ah, okay.
atención
And this can
médica
delay the
que
medical
necesita.
attention that you need?
Sí recibimos la atención buena, ¿verdad? Porque quedamos satisfechos.
Yes, or rather, if we get good attention, right, we are satisfied.
Que necesitamos siempre un intérprete.
But sometimes our discomfort is the language. We always need an interpreter.
Y también de repente a veces tenemos alguna emergencia y tenemos que ir a emergencias.
Well, for our illnesses, and also we'll suddenly have an emergency and we have to go to emergency for a sickness that comes on suddenly.
Padecemos diabetes los dos.
Both of us suffer from
Nosotros
diabetes.
Nos sentimos más cómodos cuando una persona nos interpreta, pero que esté
We feel more comfortable when we have a live interpreter in person, not on a screen.
Porque en una pantalla el intérprete, como no nos está mirando ni nosotros no miramos a él,
Because on a screen, the interpreter is not looking at us and we don't look at them.
sentimos que no hay ahí como como para que uno tuviera más confianza en la consulta.
It's that we feel that there
siempre le da
isn't
un poco
like
de
a way
miedo
to have
para
more trust in the
porque
consult.
el
It always makes us a little
intérprete
scared to talk because the interpreter
o
will
sea, nos
silence us.
dice, ya le dije que hable en frases cortas.
Or rather, they'll
O sea,
say,
eso
I
es
already
una
told you to
forma
speak
para
in short
nosotros que
sentences.
no podemos
Or
seguir
rather, that is a
hablando.
message for us that we are not able to
Pues
keep talking.
nosotros estamos muy contentos de estar aquí porque la atención que hemos recibido para nuestra salud ha sido muy buena desde hace muchos años.
For us, we are happy to be here because the attention we have received for our
Siempre
health has been very good for many years.
Nos checan todo el cuerpo.
They have always given us our medication, they check out the whole body.
Eso nos ha ayudado bastante porque
And that has helped us quite a bit
como estamos enfermos, pues nos hace sentir bien.
because we are sick and we haven't felt healthy.
Hi, thank you, Lynn, for that reporting. That's an excellent perspective and illustrates the reason we're here. I wanted to briefly mention some of the regulatory compliance. Our focus today really isn't on healthcare compliance, but when we look at our community and the impact that language has on healthcare, we should also understand that there is a body of research that grows, and disparities for patients with limited English proficiency are well documented and impact quality and safety, measurable quality and safety metrics across the board. And that has very much contributed to the growth of regulatory requirements, accreditation requirements for healthcare. So don't worry, I'm not going to go through all the regulatory outlines in every single one of these. I just wanted to mention them and point out, I put the years here to demonstrate how it has grown as we know more about how this impacts healthcare and the outcomes for patients. And over the years, it has become more prescriptive. Certainly, we are not here to give legal advice, and providers should follow their own practices, legal counsel, or institutional policies. But currently, most of us who work in healthcare are working with covered entities who must meet federal requirements. There are also state laws in Kentucky, statutory requirements and accreditation standards from CMS standards for conditions for participation and joint commission standards, insurance party requirements. And the most basic foundation for all of those guidelines is that we, as the covered entity in healthcare, are responsible for bridging the gap for communication. We must provide qualified medical interpreters for our patients and families. Ali, could you go to the next slide? And again, depending on the organization, there may be different overlapping standards to meet, but the basic requirements for language access are that we identify the individual's primary or preferred language, and that we notify the individual that we will provide the language services to them at no cost. We use qualified medical interpreters in a timely manner, and that we provide those services for patients and families or caregivers. The patient who spoke in the interview highlighted that importance of timely care. If there isn't an interpreter, if there isn't a path, we start off with a delay in care, and that's never the goal. Lynn?
Yes. we thought it would be good to let you all know what a qualified interpreter is. And a little bit of background is that there's the sign language community, their guidelines, their requirements are very black and white, and they are required to have a national certification. And in the state of Kentucky, there's also an interpreter law in which sign language interpreters also need to have a Kentucky license. And there's a board of interpreters that meets to help regulate the standards of the sign language community, the sign language, whatever you want to call it, provision in the state of Kentucky. So in the spoken language world, we are a little envious of that because there is still a lot of gray area, but we have tried and succeeded for the most part with the Kentucky Interpreter and Translator Association, which is a professional organization here in the state, to continually work on raising the standards of spoken language interpreting, and also raising the awareness of those differences between the sign language community and the spoken language community. And if you have a qualified interpreter interpreting for you, they will have a minimum of 40 hours of a nationally recognized training certificate. And there are several of those that one can earn. And that will include learning about ethics, which are obviously very important, terminology, specialized terminology in the medical field, interpreting skills, and also that both their English and then any other of their working language proficiencies have been either tested through a specific standard that I mentioned here, and or through earning diplomas in their countries of origin or in the US for English. And continued education is highly encouraged, often required. And some qualified interpreters can go on to earn a national certification to become certified medical interpreters. Both Sarah and I are certified medical interpreters. So who is not a qualified interpreter is somebody maybe a self-proclaimed bilingual. We don't take it on their word that a person's bilingual. We make sure that they're tested. And friends and family of the patient, they always mean well, and of course they can always be used in an emergency situation, but most of the time they are not going to be very good interpreters for several reasons. On the left hand side of the column, they don't have that, and plus they're too emotionally involved. So that's an explanation of what a qualified interpreter is for spoken language.
So from understanding the incredible diversity in our community and how that may look for a medical provider, to focusing in on the operations side. What does it look like to bridge the gap for communication? We have to go beyond understanding the different cultures, knowing what to expect, and look at from a patient's journey. When a patient arrives in our hospital, wants to make an appointment in our clinic, what does that language access look like? And the first step, it's going to sound super obvious, identify the need for interpreter and have that patient language documentation. But it's so often the first challenge to figure out not only how do you have that in your chart documentation, but how do you make it visible? If you capture it at registration, is it buried in 5 layers with the insurance information? Or is it right where the provider is going to see it when they open the chart? And this is just a snapshot of an example. There are lots of different ways to highlight it. One of my favorites is to have it front and center, right under patient name, age, because it is an essential component for everyone who's going to be involved with the patient, not just the provider, but also support services, respiratory therapists, financial counselors, case managers, everyone who needs to interact with this family, this patient, these caregivers for this patient needs to know. And then the second piece would be to have the interpreting resources in place or translated resources, and to check for comprehension. So to make sure that you're not just sending the information one way, but to make sure that, you know, we've got the right language documented, that the interpreting tools we're using are effective for that patient. Have the next slide. When I talk to new staff or providers, after I talk about compliance and the importance of language access, the next obvious question is, okay, so how do we get an interpreter? And that is a difficult question to answer. It really depends. There are lots of different tools and resources. I think the best answer really depends on the practice. The options could be on-site interpreters through an agency or staff, a live video feed. It's like FaceTime, but with an interpreter, audio interpreting, and things like phone services for calling a patient. For example, if you need to give lab results or make sure that when patients call to schedule an appointment, there's a way to connect to an interpreter over the phone. Depending on the healthcare organization, there may be different tools in place that are effective for that organization, or ideally a combination of different resources. It's really important to look at the work that needs to be done from the patient's perspective. Again, not just a one-on-one exam with the provider, but what happens later. If we send that patient to a lab, do we know how to tell them to get to the lab? Do we know how to give them results? Do we have information about how to take the medication we want to prescribe? There's a lot of different pieces that go into the healthcare visit and a lot of information that our providers need. So we have to make sure we have a way to effectively communicate each one of those pieces. And the next slide. Many of you may have already worked with interpreters, but this is another question that comes up a lot. What do I do once we have the interpreter on the phone? Lynn mentioned that she and I are both certified medical interpreters, and years ago we had a patient in the children's hospital, and we were paged to go up to the children's hospital to interpret for rounds, where the attending physician is going to see a pediatric inpatient. And I was outside of the patient's room, and the team of residents was talking about the case with the provider, preparing to go in and talk with the family. And I was standing outside the room, listening in, so I would know what we were going to say when we got in there. And the resident, went through the plan, overnight O2 levels, lab values. This is what we're going to do, care plan for today. And the attending said, all right, it's Dr. Beck, who is a lovely physician. All right, we're ready, let's go in. And the resident turned around and looked at me and said, well, I don't know what to do with her. And Dr. Beckett said, oh, just pretend she's a chair. Don't even worry about it. I wouldn't tell that story if it were not flattering. It was extremely flattering to me as an interpreter, because ideally, we don't want to be involved directly, stirring up what you want to do with a patient. I love that he had enough confidence in our interpreting that he knew the right way is to just be able to ignore the interpreter. We want a provider to be able to speak directly to the patient, connect directly with your family. I love to be able to be in the background, a chair. Don't even worry about me, I'm a chair. It is really helpful for that communication when your interpreter has a little pre-session to know what's going to be said, like I was doing, listening to the rounds, have a little idea of what we're going to talk about. It's really helpful as a provider to use your normal tone and speed and then pause to allow for the interpreting. Ideally, avoid using jargon and expressions that can be hard to translate. That doesn't, I mean, jargon and expressions like, instead of saying NPO, say we don't want you to eat or drink anything. But also sometimes expressions that aren't necessarily medical. Like baseball metaphors. We're gonna hit this one out of the park. Oh, baseball isn't universal. It's so hard. Do I translate like the meaning of that? If I do it literal, what part, is that good? Is that bad? That's tricky. And then there's such a variation in culture and so many different ways that people have a baseline cultural value for communication that it is essential to ask open-ended questions to ensure that everything is being understood. And then don't expect the interpreter to fill in details or provide information independently. Now, the interpreter should be connecting the clinician and the patient and not providing independent information. Have the next slide. Translation, which means written instead of speaking, can be an excellent tool. Written translations for a qualified translator can take some time, so they're not always the best option for immediate needs. But it is really great to have information like the data that Isabel provided so that you can identify what languages are we going to see in high volume, which documents might be the most essential for those high volume needs, and have them professionally translated, not through an app or an automated translation. Not only are they not compliant, they're also not reliable enough currently for medical setting. Go ahead to the next slide, please. Some tips to support communication and professional relationships for healthcare. For dates. In the US, we usually say the month first. So when we write it, we write 7/12/2023. This is especially important if your system sends out automated like text reminders or appointment reminders. So many, I want to say all, is it all other countries? Okay, if not all, most. Go day, month, year. So 7/12. Is today 7/12 or is that July 12th? If your system uses phone calls for results or appointment reminders or scheduling, unless you have the on-demand interpreting system tied in and well-utilized, text in those cases might be an excellent tool because, again, you have the option of including dates or brief messages that can be more easily understood. Culture is so broad and there are so many variations. It's very difficult to talk about cultural competency for any one group of people because we're all different, and the best expert on your patient's culture is your patient. But it can be really useful to consider potential variations like using first names or Mr. and Mrs. Differences for personal physical space or effusive emotional expressions. Some patients have strong cultural norms against physical interactions with the opposite sex. And it's okay to ask patients about their preferences, and it's also good to set clear expectations for things that may be different in other areas or other countries. For example, specialty medicine, scope of practice, the time that will be spent in the exam, or the documents that a patient should bring with them to an exam. And then it can also be helpful, especially if you don't have everything that you would normally have translated into the patient or family's language, be really helpful to recommend, while you're speaking with an interpreter in your visit, to recommend that the patient or family take notes in their own language. And that can be a useful tool. Could I have the next slide, please? Other tools and resources can also support clear communication. I know we don't have audio from the audience, but I work with nurses, providers, physicians in my organization. And when I say take your time, there's feedback from the audience on that. So I understand we're pressed. There's a lot of pressure to see more patients, and we don't have a lot of time. Whenever possible, take your time, ask questions, use support like visual aids. The image here is one of my favorite tools, and I started sharing it years ago for LEP patients, and it turns out this is actually really useful for all of our patients who speak English, patients who don't speak English, because medication is complicated. Sending a patient home with 20 new medications in 20 different bottles that they have to take on a different schedule, that is universally difficult. So one of the tools that can be used, low cost, high impact, color coding the bottles, little stickers to match a calendar. Again, low cost, high impact, with the time of day matching the color of the bottle. We do have written translations for a lot of things, but in some cases, I recommend not translating things like the medication label, because if it's not translated on the pharmacy refill, we don't want that instruction sheet to have wording that doesn't match the bottle, for example. Have the next slide. So there are a lot of tools and a lot of resources that can be used. And there are some things, specific things that we cannot do. And this refers back to the legal and regulatory guidance. So current legal standards in the federal law have express requirements for compliance and prohibitions. So we can't have a patient, we can't ask a patient to provide their own interpreter. We can't say, bring someone with you. We should not use the patient's family or friends to act as the interpreter. Never children, and I want to highlight here, this can be especially complicated in practices like adolescent medicine, where you may have a teenager who is bilingual and communicates very well in English. We have an obligation to communicate through an interpreter to the parent and not rely on that child to communicate with their parent. We can't use unqualified bilingual staff as an interpreter, and we must not segregate, delay, or deny care based on the individual's language. I have the next slide. And Lynn, I think you were going to share a little more on culture.
Yes, since culture is so important, these are some of the things that I learned and I saw firsthand when I worked at St. Joe for about 16 years. And some of it really surprised me, because I wouldn't have have thought many of these things coming from the culture that I come from. That some people from very rural areas, this may be the first time that they've ever stepped foot in a hospital, which to us seems very different. And in addition, there are people who are not familiar with medical terms and even body parts, organs, and how they function. And so when you think about health literacy, you are talking about people that have very, very low health literacy and don't understand, for instance, how the brain interacts with the rest of the body or what a liver does. And, so if you're explaining something to people and they don't have those basic terms, you're gonna lose them right at the start. And this next one is so interesting because I've traveled to Guatemala several times, and many times it's just assumed that people from this part of the world are Spanish speakers, and the majority of them are, but there are indigenous and, as Isabel mentioned, Mayan communities where Spanish is a second language or people don't speak it well at all. So we're talking about quite a few different languages, and entire families will come here, and these are people who are very linguistically isolated because it's just assumed that they speak Spanish, but they don't. And in some cultures, just as Isabel mentioned in the beginning, and this talks to the whole collective culture, you may be presenting a informed consent for some sort of maybe surgery, and maybe only the patient is there in his or her hospital room, and they may hem and haw about signing this, even though things have been described to them. And if you ask questions, they will probably tell you, well, I need to wait until my family gets here because we need to discuss this as a family, and it's more of a family decision. And then all the paperwork and legalese that we're so used to, and at this point we just kind of just sign on the dotted line, is very foreign to many cultures. They don't really understand why they need to sign, 10 times before they're even seen by a doctor. But it's very much a cultural bump, as we call it. And then our complete disclosure, which we are required to do, like in informed consent, sounds very scary to people from some cultures, because it can go from, well, you'll have this procedure and you might get a bruise, and then it has some other possibilities, and then at the end it'll say death. And I've looked at the faces of people that I've interpreted for, and they're just shocked that maybe they'll get a bruise, maybe they'll die from getting this procedure. So, and that's another example of our directness. I think we're complete and we're direct. And other cultures, they would not. They would go to a hospital and they're not going to be told any of that. Never mind that they might die from whatever they're having done that day. So it's just a little snapshot of some interesting perspectives from the difference in our cultures and these the patients that we see.
Thank you, Lynn. I know you wouldn't be here today in this talk if it didn't matter to you. But the reason we do this, the reason this bridging the language gap is important, is because it impacts the actual medical care and outcomes for our patients. So better communication truly is better medicine.
Lynn, I have stopped sharing my screen if you would like to share yours for your quick demonstration. And you are still muted, by the way.
Sorry, yes, I'm still muted. Okay, this is just one system of how you can get a virtual interpreter. And you can get a phone interpreter, you can get a video interpreter. I put it on medical. I wanted to point out very quickly that there are some you can drill down sometimes for like different versions of Arabic. And what I've learned is that if you don't know, I've been told to choose Egyptian Arabic because the movies that are made for the entire Arabic world are made in Egypt. So most people understand that version of Arabic. So, but I was gonna go to French. French is mostly French, except for Canadian, which is a little bit different. But so I am going to, and hopefully you'll be able to hear when the interpreter comes on. And this is a video interpreter that you can just access if you have an account with Boost Lingo. This is called, but there are many options for this. And it always happens when I'm doing a demo that, oh, they're gonna roll it over to audio. I'm not sure why that is, but we're gonna roll over to audio.
And while this is loading, if anyone has any questions for our fabulous presenters today, feel free to go ahead and put them in the chat.
Here we go. All right. So this is going to be a call. Yes. Hello, I'm actually on a webinar showing a bunch of people how this system works. So we had requested a French medical interpreter, and you came on and you introduced yourself, and then you gave your ID number, and then if there were a patient here, you would introduce yourself to that patient, correct? Yeah, okay. Yeah, we don't actually have one. It's just a demo, but I appreciate you coming on and helping us see how the system works. Okay, all right. We'll disconnect now, but you have a good day. Thank you. Thank you. Bye-bye. Okay, so that was just an example. You can rate the call and the interpreter if you'd like. And I will stop sharing.
Thank you, Lynn. That was great. We do have one question for you all. Do health interpreters have specialties?
We don't really have specialties where we're kind of expected to know a little bit of everything. When we get nationally certified, they do sort of test us on, certain, like a plethora of specialties. But there may be people that work in specialty clinics, and then they become specialists in that area.
I concur. And we have also seen some interpreters that have a specialty in some specific areas or mode. Some interpreters spend more time doing like simultaneous, but that isn't an official separate certification.
If there are other questions, go ahead and put them in the chat and I'll make sure we get to them, but I'm going to go ahead and share my screen one more time for those of you that are on who want to get the CME credit. This is that QR code that I was talking about that will go to the post-event survey. There's also a link in the chat. So I wanted to leave this up for a second. I'm not seeing any more questions. I do have one for our speakers real quick. So we heard earlier in the audio recording of the troubles that patient was having with just getting into the doctor and that maybe there was some delay of care issues. What advice do you have for how to handle situations like that? How could have that been handled better?
Well, it's a great question, and it's one of our biggest challenges. The burden is really on us, the healthcare organizations. That should be part of our workflow. There are different options, some depending on the organization and their needs. Some places may have a specific phone number for a specific language that connects immediately to bilingual scheduling staff or interpreters. When you have diversity like we see in Lexington and at a large organization, hundreds of languages, you can use a tool like phone interpreting and make sure your staff know when a patient's calling to request an interpreter, this is how you connect to the phone interpreting system.
We have several questions that have popped up about getting the recording from today. You will all get a copy, so you can share it with whoever. So I wanted to go ahead and answer that. We have someone who is asking, could we provide standards or policies for local public health departments for them to use? If that's something any of you have, I have gotten that person's email and you can send them to me and I'll get them onto them. So, okay. One comment we do have is glad you all addressed how to act with an interpreter. Treating the interpreter like a chair is a good way to remember how to do it.
Okay, thanks. But just to clarify for the interpreters who may be on, I'm an interpreter. So I meant that with the most respect.
Hallie,
Go ahead, Isabel.
I have a quick suggestion for also working with interpreters so that when we're speaking to someone and it's a language that we're not familiar with, so we can't really gauge the quality of interpretation or the understanding. It's not necessarily quality, but the understanding of the individual. Rather than asking, do you have any questions? Because that's a hard one to answer on the spot. But if you ask the person to repeat the information that is important, that you've relayed, when they repeat back what they have understood, that's where you see where the gaps in understanding will pop out pretty clearly. And it's just something that we do routinely here. We ask them, please repeat what you understand from this meeting. And
That's
then
a great suggestion.
the other thing is that I would ask the public who works with people from all over the world, we're both on a learning curve. It's a learning curve for the newcomers and for us as well with their particular culture or country or language. So I think that a really nice thing to do is to explain American culture that may be confusing to them, like the the smiles, that means we're friendly, not that we're laughing at something, or using first names, that again, it's a sign of friendship and not a sign of disrespect. So whatever you think might be helpful to the newcomer would be very appreciated in the years to come for them.
Someone has asked, they said they would like to get certified as a medical interpreter. Do you all have any recommendations on schools, courses that align with Kentucky laws that they should be looking for?
Yes, I have all that information. They could email me. Kentucky Interpreter and Translator Association has all that stuff.
Okay, I'm going to be sending out a post webinar email to all of you that are on, and I'll include ways to contact our panelists from today for any follow-up questions, so you two can get connected that way. All right, I know we're over on time, but it was really great and I think worth it. And we're not that over on time, just a few minutes. So just thank you again to our speakers. You all did such a great job. I'm so happy that you were willing to give your time and knowledge to this. Thank you all who attended, and that's all I've got. So hope you all have a great rest of the day.